on. Now we're on. Okay.
No more.
Welcome to the Healthcare in Danger panel. Let me commence with a brief impression from the field. The perpetrators continued with angry thoroughness. Beds were slashed, bottles of blood serum and medication were shattered. And then the armed group in their filthy camouflage suits began to assault on the few apparatuses. They were not satisfied until they had rendered the only X-ray. Dann macht bitte was mit dem Mikrofon. Geht das lauter?
Let's start again.
No, I start here. They were not satisfied. Geht das jetzt? I am not satisfied until I'm here.
You're ready. On.
Yeah. You are much louder.
Do you want this one?
This way. Yeah. They were not satisfied until they had rendered the only X-ray. This sounds like in a church.
You take to the first lesson.
So now that you've spoiled my beginning. Ist das okay jetzt mit der Lautstärke? Es klingt wie der Papst. The perpetrators continued with angry thoroughness. Beds were slashed, bottles of blood serum and medication were shattered. And then the armed group in their filthy camouflage suits began their assault on the few apparatuses. They were not satisfied until they had rendered the only X-ray, the sterilizer and the oxygen apparatus unusable. Each of these zombies knew that an end of the fighting was not in sight. Each knew that on the very next day, their life could depend on whether a doctor was there to patch them up. They evidently wanted to destroy their last prospects for survival. The notion of future has disappeared in the collective rampage. There is only the present. There are no longer any consequences. The regulation of self-preservation is no longer in force. This is a paragraph of Hans Magnus Enzensberger's pretty far-sighted book, Views on the Civil War, in which he describes an attack on a hospital in Mogadishu. The book was published in 1996, and Enzensberger predicts how civil wars will be run in the near future. And it seems that 17 years later, we are at the point. A recent study carried out by the ICRC in 16 countries matches the predictions in this book, and according to the authors of Healthcare in Danger, the study identifies one of the biggest, most complex, and yet most under-recognized humanitarian issues today. But it does not just point out that healthcare is in danger in war zones. It also points into the direction that conflicts these days are being fought with massive disregard of the law of armed conflict. And as Enzensberger puts it, even without the regulation of self-preservation. The question is thus, are we drawn back into times of history we thought we had already passed, into the pre-Geneva Conventions era, when conflicts were fought recklessly and indiscriminately? The ICRC study Healthcare in Danger is the initial point for us to tackle these questions. Let me briefly introduce my panelists today. Jasveen, to my right, is Senior Gender in Emergencies Specialist with Care International, based in Delhi. She has an extensive expertise in linking gender issues with health issues, with an emphasis on sexual and gender-based violence. We are looking forward to learn more about CARE's Gender in Emergency strategy today. Alistair, to my left, is Humanitarian Director with Caritas Internationalis, the global network of 165, I think, national Caritas members, and based in the Vatican. So, any gossip about the next Pope, you're most welcome.
It won't be a woman, I'm afraid.
Alistair has led several relief operations and worked in over 30 countries on nearly every continent in the last 15 years. Yves, to my right, is Director General of the ICRC since 2010. He has joined the organization in 1992 and worked as an ICRC delegate in the Middle East, in Sudan, in Yemen, Chechnya, and Georgia. I'm Robert. I worked as an ICRC delegate myself, and I'm now based in Vienna, heading the staff unit for social policy and humanitarian diplomacy at the Austrian Red Cross. You are the audience, and only your questions and remarks will complete the keynote and the statement of the panelists, so we are looking forward to them. I'm supposed to, the organizers told me, but I think you already know, I'm supposed to point out that this panel discussion is being live streamed, and I hope that many people follow it on the Humanitarian Congress website. Yves, as a starting point, may I ask you now to provide us with an overview about the findings and the conclusions of the healthcare in danger study. Thanks.
Good morning. You don't mind? I'm coming close to you because you're far away. I hope you can follow me like that. Very good. Good morning to all of you. Can I just make a personal remark? When you are from the podium, I'm just looking at this room, which is a remarkable room, and I see that 75% of you are women. Is it linked with us or with a former debate? But it's interesting to look at that. What I would like just to tell you is why healthcare in danger is so important for me, for my organization, but I truly believe also for all of you. Humanitarian, healthcare professional, citizen, and what can we do about it? And I really do believe, as I've seen in the previous debates about gender balance and gender questions, I really do believe that your input will be very valuable in terms of debate, but also having a perspective, because you could have a different perspective about healthcare, and it will be important to get your perspective about it. Maybe just to start, and I think it's important for you to have, I'm really born in this organization, and my organization is born really from, in fact, the war on battlefield, exactly 150 years ago. Don't worry, I'm not going into history, but I think what is important for you to know is at the time the idea was very simple. A wounded person, even if he was your enemy, should be respected and treated. That was really basic. And this idea is still absolutely there at the core of our work, and I think of humanitarian work. What I find amazing is that 150 years later, we still have to worry about that. And that there is a sense that maybe today, we've not progressed as we should have about that. And here maybe just to give a sense, and I don't want to go in all detail about the study, but I want to give you a bit of a sense of what worries us. Why are we nervous about that? I would say a few years ago, when we were discussing with all our doctors of ICRC, but also Red Cross colleagues, MSF colleagues, all that, there was a sense that hospitals were more targeted. And it was more difficult for medical personnel to do their job. We know that. We've seen that over the last 20 years. This is nothing new. But it was difficult for us to really capture. Was it a trend? Was it something, specific? Did we know about it? We found it difficult to understand the problem. That's why we did the study. It took us 2 years. And I must say, we want to continue the study because it's critical for us to understand the issues. And what we've seen, and this is two important issues. What we've seen is the magnitude of the issue is bigger than what we thought. And I'll come back more into detail. But what we've seen is it affects patients, health worker, health facilities, humanitarian. It affects also entire society. If you look like Afghanistan, for example, the pressure it puts on a society, on women to start with, but on the entire society, not to have access to health facilities, for example, it is enormous. The cost is enormous. But look at Syria also today. You know very clear that it's not just the hospital or the first aid or the wounded. You understand, you feel it, and we feel it. That has an enormous impact on an entire society. And I'll come back on that one. So there is one issue, and it's confirming the magnitude of the problem. And the second issues which make us, in a way, so worried and so concerned about this problem is that, in fact, we feel that now attacking a hospital, putting pressure on doctors, arresting them, targeting health people, going inside the hospital, killing patients, is not so much anymore a problem. In a way, it comes like, sometimes people are reacting, we've seen that, but as a normal act of war. Yeah, as you mentioned, Ensenberger, civilian war, let's in a way, that's part of war. This is part of civil war. And we want to say, no, not at all. I mean, even in war, even in a war situation, healthcare facilities, personal, patients need to be respected. And it seems to us that there is a need to remobilize ourselves on this very basic principle. Now, if I just go a little bit more into understanding the issues, and this is where we will also need you, and this is where we continue to do the work together with our colleagues, together with MSF, together with Red Cross, Red Crescent Society, to understand what are we talking about. And you will see you can have different perspective. I think Alistair, but also Jasveen will give different perspective about healthcare in danger. But if you try to understand why is it in danger, what's the problem? The first problem is that we see that access to health services, facilities, is difficult, and it's complex in some countries. I just mentioned Afghanistan, but if you look at northern Mali, for example, for the last 12 months, for people, families, to just get access, you are displaced, the fighting is going on, to just get access to normal health is a big issue. So it's a classical issue, which is insecurity, linked to violence, linked to conflict, which make access to healthcare problematic. We know that, we're not surprised about it, but sometimes it has a major impact on population. Northern Mali is a good example. The second issue, which for us is something new by its magnitude, is the fact that we see more and more in conflict that there is not only a targeting of health worker, but there is a systematization of the targeting, part of a strategy. So if you want to put pressure, if you want to terrorize the other or your population, you start to put pressure on doctors, hospital, you arrest them immediately. And we've seen that in several contexts over time. We knew that, but the systematization is a surprise for us. And we need to grasp it. And clearly we have this impression in contexts like Syria, but we can look at Bahrain and other places where clearly from day one, it could be from the government, could be from non-state armed group, that there is a clear will to target and they know exactly what they're doing. And we've seen that in Afghanistan and other places where people know exactly what they do. Right? And that's a big worry for us, because of course that's put pressure on the entire population. We see also, and that's not a surprise, targeting of patients in some situation, but also, and I think it's very important to grasp that, that's something new for us, was what we call the knock-on effect on pressure on healthcare personnel facilities. And Iraq is maybe the better example. In Iraq, and it's difficult to have figures as always, and take the figures with cautious, but just it gives you a sense of what we're talking about. In Iraq, between 2006 to 2007, something like 600 to 700 doctors were killed. It was part of an enormous violence in Iraq. They were not the only one targeted. Some of them were killed because they were at the wrong place, at the wrong moment, where they parted at the wrong ethnics. That was one issue. But some of them were really, truly targeted. The result is that in 1 or 2 years' time, half of the doctors left the country. So 50% of the 34,000 doctors in Iraq left the country. So you have a country which found themselves with almost the entire, let's say, competent professional leaving the country. And that has an enormous impact again. And that's what we call a knock-on effect. You can see somebody being killed, you say, okay, it's terrible, but then there are knock-on effects. It means thousands of people who don't have access anymore to healthcare. Right? Our sense, and here I'm careful about that because we don't have the figure, even if we work within Syria, it's difficult to really grasp exactly in terms of trend and figures, but our sense that in Syria, we're confronted with the same problems, that you have less and less medical personnel from Syria being able to carry out their action, not only because the hospitals are sometimes just in the front line and they are under pressure, but because also they feel themselves being targeted, not respected. So for them, it's better to leave. But what does it mean in a country where in the midst of the conflict, you have 30, 40, 50% of nurses, doctors leaving? That really has an enormous impact on the country. And of course, that leaves us trying to find solutions, which is something important to look into that. So I think what seems for me important when you then start to unpack it a little bit, and you zoom in terms of issues, so you can see there are issues related to access, there are issues related to targeting, there are issues related to the lack of respect, and sometimes, especially, and here it's close to Enzenberger, when the war happens in urban area, for example, very difficult to protect the hospital, we've seen that. But it's also interesting when you start to zoom in and try to look who is really the first one to be targeted. And here 70% of the incidents we have seen, 70% of the people targeted are local personnel, right? So the local personnel, the people on the ground are the first ones to really be under pressure. Absolutely. Throughout the 16 countries we've seen. Absolutely. And that's really correspond to what we've seen everywhere. So the local personnel, the local health worker, sometimes the national NGOs are the first one to carry out, really to be under pressure. And then 17%, only 1/7 only. It's Red Cross, Red Crescent, and then a little bit less than 7% UN or international NGOs. Just to give you a bit of a sense of what we're talking. So 70% of local health workers being targeted. You can link that, by the way, with other issues like, for example, journalists. When you look at the protection of journalists, the journalists who are dying, very clearly you can also saw that you have something like two-thirds, 3/4 of journalists who die today or under pressure are local journalists. But just talking that, so that's the first one to look. The second issue is if you zoom in a bit again, I mean, among them, most of the 1/3 of the issues are related when you look at all the incidents and you look at what happened to them, and to kind of again to impact a little bit, what you can see the first thing is they are harassed. 1/3 of the incidents, the people are harassed. They're not killed, they're not wounded, but they are harassed. They're blocking a checkpoint, they are under pressure, and this is very clearly has an impact on them too. Then something like 12% of incidents, people are killed. So when you look at all the incidents we are monitoring, 12% of the incidents result to a killing, and 11% beating, wounded, and 10% of being detained. So it gives you a bit of a feeling of what are we talking. For us, it is maybe the first point when we want to mobilize ourselves, and mobilize yourself also, and have a sense, we need to have even a better understanding of what are we talking. So we will continue to really, on every delegation of ICRC together with the Red Cross, but also MSF, to be able to understand really the issue very well. What are we talking? What are the issues? Is this trend confirmed? We will see with Syria, is this trend confirmed overall in a different context? So first things, really to make sure that we continue to understand, to unpack the issues, to see what are we talking. The second question and the second point where we can, I think we need to do better is we need to mobilize ourselves and feel responsible about these issues. And the message very clearly coming from the study, but also from us at the ICRC was, it's an issue goes beyond our organization, goes beyond, I would say, humanitarian as such. We need to be able to mobilize also health practitioners. They need to be part of that. They need to come with their vision to push us to mobilize. We need to mobilize army. They are central. Because one of the issues we see constantly is harassment of ambulances in checkpoints. Very big issue. It doesn't look like that as a big problem. But when you stop constantly each ambulance to cross a checkpoint for 2 or 3 hours, and you do that as a practice, because you are searching for weapons, as an example, it has an enormous impact on people and on health. So how do we do that? How do we discuss with military? How do we make sure that when they conduct search in hospital, they do that without weapon, respecting it? We cannot just lecture military. We need to have workshop with them. We need to understand what are the rules, what are the procedures. We need to be able to see if we can improve that. That's absolutely critical. So we need to mobilize army. We need also to mobilize, to discuss, to engage with non-state armed group. We need to be able to discuss this issue with the Taliban. We need to be able to discuss with the Hamas, with the Hezbollah. We need to be able to sit with them, see what are the issues, how are the problems, and really being able to engage with them. That's absolutely critical for us. So yes, first element, engaging beyond our community. So that's critical. We have a very, very clear ambitions to mobilize ourselves for the next 3 years. We will also mobilize states. We will use the International Conference of the Red Cross, Red Crescent. I think you know that, who brings every 4 years all the states together with all the Red Cross, Red Crescent. We received a mandate in 2011 to start to work on that. We will work in 2015 also, when we will collect all the information, mobilizing, to try also maybe to work on national legislation. Because that's my last point. What strikes me, what strikes us is the law exists. The international humanitarian law exists. The national legislation is good. We need, again, to make it respected, understood, and maybe trickle down into practice. You know, rights and obligation of health worker, that's critical. But also rights and obligation of military, and we need to be able to look into that. And I truly believe, I think we truly believe, if we take a step back, that if we're not able to gain a little bit of traction, to make sure that in context that we see today, wherever, that there is not more respect for healthcare, and I really would like to insist, wherever, not only in Syria, Afghanistan, Colombia, but also in Europe. I don't know if you remember, for example, some of you are football fan. When you look, or remember maybe France in 2005, the riots, I mean, ambulances were stoned. Right? They were not respected. So it's not just happening there. I think it's critical that we are able also to make sure that people are aware, understand that even in a violent situation, that ambulances, that the Red Cross, that health workers are respected. If we're not able to bring that back, I think then we will really fail. And I really am worried about then humanity, because I'm convinced that at the core of humanity is the ability to be able to treat the wounded when there is a need, and to have a safe space when war and when violence happen. Thank you.
Thank you, Yves. So it's not collateral. They know what they do is a key sentence for me from your keynote. And it is actually striking when you read the study. 34% of attacks against healthcare facilities and personnel are carried out by state, army and police. These are people who are supposed to be trained in IHL, who should know what the Geneva Conventions are, and still something doesn't seem to work here. So we are talking about the deliberate discrimination against people who are trying to access health care. Jasveen, are women particularly affected by this discrimination?
I think I'm going to just, before I get into that,
right,
respond to a few things that Yves raised. And within that context, what you've outlined is first the magnitude of the scale of this issue and the targeting that's happening. The second part of it that was highlighted was issues of access. And the third part was the engagement and the challenges around engagement with state and non-state actors within conflict scenarios that we're working in. If you underline all these three issues within the context of gender discrimination, and the first session that we had today morning of looking at different needs and opportunities, if you underline it within the context of saying that these are countries that are traditionally being either fragile or developing countries, so the basic systems themselves are not in place. Access, even in regular circumstances, is a challenge. And then you add conflict, and then you add violence to that scenario. It just changes things substantially. And one of the challenges that we face, and by we I mean not just international NGOs, but the wider community that's looking at addressing gender equality programming, is how within healthcare systems, how within education systems and other kinds of basic services that we are providing within these contexts, these issues are particularly addressed. So the understanding, the nuances that are required to understand access in different contexts, you can't have a one-size-fit-all. So how are your strategies and responses being adaptive? And especially something that was raised particularly in the first session, which I think probably resonates across the different panels that we are having today, the kind of analysis that is required and how that analysis is actually then used in our programming. And something most organizations struggle with, given the rapid onset emergencies or the scale at which we need to scale up, or as well as the immediacy of the response. The one thing that within a healthcare system I particularly find challenging and engaging with the healthcare system, which responds in conflict situations, is where does gender-based violence, responding to issues of gender-based violence, responding to sexual reproductive health concerns within the context where your basic services are not being met. So where you're looking at psychosocial support services, where you're looking at services for clinical care for survivors, especially in context of conflict, we have enough evidence over the last few years that GBV increasingly is being used as a tool of war. And then the implication that has for the way we design and respond is something I would like to talk more about, and also hear more questions from the audience on those issues. Yeah.
Right. Thank you very much. Jasveen, you stressed the importance of taking into account the different contexts in which this discrimination happens. I've already mentioned that Alistair has worked in more than 30 countries. So how do these experiences fit into your personal experience as a relief worker?
Thanks very much, Robert, and good morning, everybody. If I start first by taking the title as it was given, and I'm reflecting on a number of current and recent crises where Caritas has been active in healthcare. I think, Yves, you've given a very good overview of the implications of conflict for healthcare. I would very quickly highlight a few, some of which you've covered. I mean, firstly is direct hits on healthcare, whether they be deliberate or considered collateral damage, whether that's an acceptable term or not, I leave with you. But then the caseload soars enormously. So hospitals, very often in areas which are already stretched with the normal caseload, we have instances where the number of beds have been increased by a number of 6, and we still have multiple occupancy in beds. So the number of cases soars enormously. And we're left treating without adverse distinction. So it's people of all, whoever reaches the health facility, irrespective of which side of the conflict they are, and the people themselves. And so that's all part of the dynamic then within this very tense situation. And access, you mentioned, the actual ability of people to get to the health centres or hospitals in order to get the care. The staff we have are exhausted very often. They're working incredibly long hours. Many of you will have seen this. There are some really heroic actions on the part of people who are driving themselves at superhuman levels to try to treat the number of people that they have. They have enormous commitment, and very often, Yves, you had the statistics, it's their very safety and security which is in jeopardy. Something as basic as medical supplies can become depleted, so you have staff and facilities on the ground, but you don't actually have the medicines or dressings to treat people. And supply routes can be interrupted and very difficult to manage. There are a number of situations now. Syria is one, some of the areas in Burma and other countries where we're working, where actually we have the issue of international borders, which there are issues of sovereignty and mandates of organisations to actually provide materials across those borders. So all of those are some of the dynamics we see within healthcare. Taking some of a kind of meta view, as Yves said, national bodies, whether they be governments, militia or parties to conflict, I think there's a ruthless pragmatism which has crept back in. That question, have we gone back to the pre-Geneva Conventions era? There was a recent book by the Feinstein Institute which was saying some of this, the discussions around instrumentalization of aid, they're not new. Those things have been there for a long while. But perhaps we had an era where some of the principles were more broadly accepted, and have we lost some ground on that? But also our own governments. I think national governments where we're working are watching our own governments, and they are seeing the degree to which aid policy is linked to national interests, and they're asking questions about how they link their behaviour to their own national interests. So I think I see national governments mirroring the way our own governments are working. If I go back to the title we were given and listening to Yves talk, it's all about us. It's all about health professionals who are hurt or killed. It's all about healthcare in danger. I want to say what is in danger. It's people who are in danger. And then, if we're talking about the care that people receive, healthcare is a very partial answer. So, it's not a cheap trick to say, let's put the people back at the centre of the analysis, because there are issues of dignity in that, and their own agency, their own self-determination and self-actualisation in that. But also, we have to meet people with a personal concern and be open to their needs as they express them to us. And that brings me into what do we do about it? I think it has always been, it will always be, a very thorny issue of negotiated access. But on what basis are we able to negotiate our access? And something all of the agencies at this table have done a lot of work together on is the basic humanitarian principles of humanity, impartiality, independence and neutrality. And I'm sure the Red Cross are delighted that I've mentioned those today. But I want to just look quickly at a couple of them. Impartiality is great, but it's not just a question of who do we work with. Yes, we work with everybody, irrespective of where they come from, whatever their political allegiance, ethnicity, their faith background, whatever it is. Yes, we do that. It's not only a question of who do we work with, but how do we serve them. And that's where I think there's a real question about mandate and our ability to have a conversation with somebody and say, how can we help? What do you need us to do for you? Because if they say, we need water, and you say, well, I do healthcare, how impartial are you really? So impartiality, yes, but a much richer understanding of impartiality, I would say, than we often hear at the table. And the other one I would give is humanity. When we meet people, we meet them as entire human entities with unique dignity, and we have to treat them with all of the different facets of the human person. So yes, the physical need, but also the emotional, the social, the spiritual and the psychosocial. So we need to be able to meet people with that broader view of what they are and what they need as they express it to us. Because I think in order to be able to talk to the belligerents in conflict, in order to be able to work in areas, we have to be able to build the trust and demonstrate that we are living up to those principles which are about how we engage as human beings, rather than how we arrive with mandates or particular agendas which they're already skeptical of.
Thank you for this reminder, Alistair. Now it has been mentioned twice already. Are we falling back into an era before the Geneva Conventions? Are the basic humanitarian principles no longer in force? I think I have to give you the opportunity to respond to that, Yves, and I will then open the floor for questions from the audience.
I switched it off, sorry.
Sorry.
That's right. One way of silencing the ICRC.
and it won't work. Yes. We are back, full force. Maybe I'm absolutely of a different opinion than to say that, you know, before the 19th century, let's say, things were perfect and it was cool and a lot of respect, and we are back to that. I don't think so. I think the reality is war are changing. The nature of war is changing, and that's what it is. So what we're talking is that, and I think we can go on for a while because there is a lot of issues. But roughly speaking, if you look at 2 or 3 key elements, one, and you know that there is much more internal war than international war. We know that, and the war are about people. They are where the people are more and more. You don't have armies, you know, there and then the other army is there and then you have a perfect places and this part of the country is well occupied against this part. Look at Syria. Syria in that sense is a terrible modern war in terms of modern being actual. I mean, the front line are numerous. Almost every city in the country is shared with different front line. The country is not absolutely perfectly one side or the other. So it means front line and war really are among people. And that changed things because it means, of course, the people doing war then, their strategy is to control people. That's their objective, right? And of course, it changed the way they're doing it. And when you say that's 34% of actions or problems are related to army, that's not a surprise. And it's not just about respecting the law. It's because it's sometimes part of the strategy. And that's maybe the big worry I can see. The other element of war, and we know that, is the famous asymmetric warfare. I'm careful about the wording, it's not a perfect one. But let's say where, in fact, one side sometimes have and will play symbol, will put pressure, right? And of course, then healthcare, hospital, humanitarian are also symbol. And when you really hit them, the message is very strong to the entire population. And last but not least, there is more and more war in urban area. Because we are more and more of us living in urban area, which also have an influence on then the facilities, on the way the war is fought. Look at Gaza, for example. But look at the time, Chechnya, look at Kabul. I mean, all these places makes that in war, it starts to be difficult sometimes to distinguish what is a civilian objective against a military objective. So yes, there are questions, and how do we tackle that? So my point is, no, I don't think we are back to pre-Geneva, but we need to engage, and that links to you. How do we engage? How do we understand what military are doing? How do we discuss with them? How do we also discuss and engage with non-state armed groups? How do we make sure that there is a minimum of accountability? And that's the real questions, I think, which affect all of us, I think, in that sense. The second issue I just would like to react is also Alistair, but also Jasveen. It's true, healthcare in danger, it's not about humanitarian. We should be very careful. It's not about us. It's also about us, but it's not about us as first. It's about the people, absolutely. But it's also about our ability then to help the people. And I would really be careful to say it's about patients, it's true, it's about people. It's also about health professional, it's not humanitarian, health practitioner, local health practitioner. And here I have a slight difference with Alistair. It's rare, but it happens. On that one is I'll be careful not to mix everything. Because of course, sometimes it's important that we square or we try to say, what are we talking about? If we talk about the way we operate, if it's about, you know, how do we do and bring help to people, it's critical. It's not then just about health. And then you open everything. I would like to frame it about health. It's already big, but it's truly about healthcare. How healthcare is provided, how much people have access. And I really like what Jasveen says. We need to have a better understanding of the system. We need to impact it, because this nuance will help us to adapt our response. And this is the key element. And again, to link it with Alistair, that's the only way to understand and to be able to provide a real response. And here, the only way is very clear. It's when you understand, and to understand, you need to be close. You need to be aware where it's happening. So I think the question here, and maybe the issue for us, and here it's good to take in terms of responsibility, is also for us, what we need to look at is how are we able to be where it's happening? How are we able to be close to the people, close to health doctors, to health facilities, to understand the problem? And then maybe what is important for us is how are we able then to share the data? I think this may be something we need to learn and try to do that in order to have a good sense. But it's first and foremost on that case, on health, it's nuance. We need to understand that. It's complex because we need to work on the systems. But on the same time, so let's focus on that if we want to be able to help the people.
Well, a few different thoughts. And why am I taking? I'm going to take a second.
Let's be free.
Liberation on Women's Day. Ow. These were designed for men with short hair.
It's not very comfortable either, I believe. Yeah.
I think I definitely agree with a few things that Alistair said, and looking at the shifting nature of conflict and war, which you mentioned, but also looking at human beings as human beings and the way we end up within the humanitarian community, dividing ourselves within sectors and the kind of response we do, and the specializations and the subspecializations sometimes takes away from that. And one of the challenges related to that is then how do you engage with local capacities? How do you engage with local systems and structures that exist? And it's not just about an external aid and an external agency that's coming in to deliver something, but what exists within that context traditionally, what are existing coping mechanisms that individuals have. And a lot of these countries where we do operate are countries that have a long history of conflict or violence in different ways. So it's not that you're starting from scratch, which is sometimes the mistake that's been made in contexts like Afghanistan, in other contexts where you feel that where the assumption is you're starting from a clean slate, that everything that was there was destroyed without acknowledging what was left behind. And those are the challenges that we are seeing now when that shift within the country is happening of saying we're going to be withdrawing our troops. The way the withdrawal, the way the dialogue or the nature of the dialogue that's happening around humanitarian aid within that context, where it connects back to political agendas, where it connects back to where our aid comes from, where the money for delivering healthcare comes from, the agendas that do occasionally get attached to that. So I think it'll be interesting to see if we can also raise questions on states and resources that are made available for by states, but the conditions that are attached to those resources. The other aspect that I wanted to look at was both within the context of what's happening in Mali as well as what's happening in Syria right now, where 1/3, 1/4 of the hospitals and the healthcare systems has been destroyed, where access is for all different agencies are looking at ways for negotiating that access from multiple sides and multiple levels. This is where I strongly feel that we need to look at how, as a humanitarian community, we also link up with the development work. So the organizations that have had presence in these countries where we've done longer-term development programming, where we have relationships with these communities which predate conflict, which predate the crisis, and how development workers or those wings of our organizations and the linkages that we need to make between these two. And I mean, especially in contexts like Sahel and the Horn of Africa crisis, and in what's happening in Mali, where we do have those individual relationships with communities where presence for most organizations stopped at a certain point. How do we capitalize on that, and how do we build on that is something that we need to look at. The other issue which I felt we need to unpack and explore a little more is diversity and how that relates to the shifting nature of conflict. And assuming that these populations are one and the same, but again, in Afghanistan, Syria, Mali, Kenya, Somalia, just the diversity of those populations and the relationships across those different groups. So it's not just a question of setting up the systems, but systems that acknowledge and accept what those different levels are. And the last piece is, I think, related to, again, the shifting nature of conflict is how it's not just about physical and material needs anymore. And a lot of something that as a humanitarian community we are a little uncomfortable talking about and acknowledging is the spiritual needs that individuals have and how that relates to the way the world is perceived, as well as how you engage with different parties on that. So as humanitarians, if you ignore that need of individuals, which is as basic a need as physical needs in certain contexts, you live with the repercussions and the results of that then.
Thanks.
As I said, I would open the floor for questions now. Are there any questions already to one of the panelists? Ulrike von Pilar, please.
Thank you very much. Ulrike von Pilar from MSF. I have two questions, or one in two parts to Alistair. And how can you be a humanitarian and depend on the Vatican? I really have a problem to understand how you interpret neutrality if you depend on the Vatican. How do you interpret acting independently if you depend on the Vatican? It really, for me, it's an almost incomprehensible tension. And specifically, that's the second part on the women. As we are here, I've been reading this morning that there is the annual meeting on the status of women, I think, at the UN with 6,000 participants. And I'm reading that it's the Vatican, the Iran, and Russia that are again refusing to accept rape within a marriage as a fact. I don't know much more about the current discussion. Maybe you know more. I just imagine, I have many colleagues and friends in the Caritas. It must constitute quite a dilemma. And I would really like you to try to elaborate a bit on how do you deal with these tensions? Because, yes, as I said, how can you be a humanitarian and Catholic Church at the same time? Thank you.
Is that on the topic? Want me to answer that? Gosh, thank you very much. Yes. Where to start? The church is a very broad organisation, and indeed, and there are differences of opinion in that. I think, and the one position you've articulated, I know many who would have problems with that. I don't know what the grounds for not accepting rape within marriage is. So it's very difficult for me to comment on that. On the broader question of a humanitarian within the Catholic Church, it's absolutely fundamental to who we are. And it goes right back, sorry, this is a forum, I wouldn't normally make reference to some of these texts, but right back, Yves mentioned 150 years old, I just go back 2,000 years, but some of that stuff of the parable of the Good Samaritan, And the person who was walking down that street wasn't the priest, wasn't the person you would expect to do good works, but came across and met the person lying in the gutter and said, I actually have to do something for him. And took him back to the hotel and made sure he was provided for and said, look, keep looking after him and I'll come back and settle the bill. And that's absolutely fundamental. That was not the Vatican. But nor is Caritas the Vatican. We are an institution within the Vatican, just in the same way as Caritas Austria is an institution within Austria. And yes, we are inspired by church teaching, but we're not bound by, if they say no rape within marriage, we're certainly not going to say there's no rape within marriage. That's a discussion we would have to have. I'm not sure, like this, I'm going to answer the question, but I'm very happy to talk about it over coffee later.
That's what I was just about to propose. Other questions which are a bit more on the topic from...
Sorry, but perhaps while you're waiting for a question...
No, go ahead.
I'll say it later. No, let's hear it.
I wanted to pick up on the issue of instrumentalization of humanitarian aid and the challenges, I think, that we see in maintaining that neutral, independent, impartial humanitarian space in the context of military and political actors taking up space in what is traditionally been a protected humanitarian space, and how we can influence armed actors to respect that space and stay out of that space and not instrumentalize that space. An example that comes to mind for me is the use of the vaccination program in Pakistan, and now we're seeing a direct targeting of health workers, particularly vaccination workers in the polio campaign, being targeted in Pakistan. And I think, you know, in order to ensure that healthcare is not in danger in times of conflict and violence, and that humanitarian actors are able to continue to access those in need, we need to deal with this issue of humanitarian space. And I'd be interested in comments from the panel on this point.
Excuse me, would you mind mentioning your name and the organization you represent?
No problem. I'm Jessie Thompson from Care Canada.
And posing your question to who?
Whoever.
Okay, who wants to pick it up? Yves?
Yeah, I'll have a go. And
yeah, right.
The I can't even say it. Instrumentalization of aid. And I understand how politicians find themselves there. If you're in the political endeavour and you're looking at the business of government and using all of the assets, or all of the means you have at your disposal towards ends that you think are good ends and ends you should pursue, then I can see how you might say, well, I can see the part military might play in that, and development might play in that, and humanitarian might play in that. So I think it's an understandable position for politicians to arrive at. But I think in my discussions with politicians, they have rarely understood the implications of instrumentalization. There you are, hooray, I said it. So I think there's a real job to explain to them, if we're going into a particular area and they think we're associated with nation building, regime change, or whatever it might be, we will not have the trust of the people we're there to serve. And so I think some of it is, it makes perfect sense, but the devil's in the detail, and you have to really explain the detail for it to no longer make perfect sense. Some of the work, as the steering committee for SCHR, the three of us who are on the panel actually have done quite a lot of work on the humanitarian principles and trying to raise those again with governments and saying these are important. A report that Caritas did recently talking about the EU consensus. And I'm pleased to say that the EU consensus is a very strong endorsement of humanitarian principles. And one of the things, or two of the things we've been saying then out of that is, first and foremost, please can we maintain the principles within that consensus, because as an EU document, that's really powerful and we need that. And secondarily, how can we work with states to ensure that they put the EU consensus into their own domestic policy? But I think we have to, it's about explaining how it undermines the very humanitarian endeavour, and when they understand that, I think we go some way to addressing that force that's upon us. Yves.
Great. I think it's a big issue, and I'll try to, we can take it from a different angle, but I'll maybe give you three elements of it. The first one, I think it's something we just need to be aware, is we will go more and more in a situation in our world where there is a major tension. On one side, the tension is to go for simplicity. It's normal, right? Integration, efficiency, so it's one UN. Of course, I understand that, where you go for it, for integration mission, you do the same times humanitarian aid, development, justice, military, nation building, the trend is heavy. And in a way, when you are public, you're in media, you're a parliament, you want this efficiency, it looks efficient, it's clear, and you want to have one visions about crisis. You don't want to make this distinction between the type of crisis, we're talking about humanitarian crisis, one way, one system. And there's a very strong, I would say, push and tractions for that element. And not only, by the way, on politicians, for all of us, the way we communicate, the way we connect, the way people understand that. And at the same time, more than ever, there's enormous differences between each contexts. And we need to be able to come back with the differences, because Afghanistan is not at all the same than Pakistan. And I would even go one step further. Baluchistan in Pakistan, the dynamic is totally different than the one from Islamabad, to take one. And I can go on and on. So I think one of the issues for us is how are we able at the same time to have these macro discussions and not being, in a way, thinking this is reality. This is not reality. We need to be very careful with that. Right? I think that's just one element. The second one, can I just come back to us for once? I think it's useful to say government and non-state armed group, they are bad, whatever. Truly, and we can discuss. I think we need to look at us, and us here is a humanitarian, right? It's us, a collective us. Frankly, if you look at the last 10 years, the behavior of humanitarian, and some of us, let's say at least, we should really look into that. The way we are, in fact, continuously claiming like a mantra that we are all principled, but what does that mean in the field? Where are we really? And I think there are some clear trends. If you look over the last 10 years, we have never been so many professional humanitarians on earth. Great news. On the same time, where are we in Mali? In the conflict, not outside. Where are we in Syria? In the conflict. Not talking about cross-border, but doing cross-line. Where are we in Afghanistan now? And prepared to do the work, and not just in Kabul. Where are we in Yemen? Not only in Sana, but also in Sana. What are the methods we have put in place, and here I totally agree with you, to manage also long-term, because we are dealing with long-term crisis. And here, I think I would really put that on the table. It's a question. We need to look at our model. We have among us a lot of key organizations who are saying that they have direct access to all these places, but the reality is they have access through their partner. So we have outsourced, and it's we that I cannot take for ICRC, but let's say we have outsourced the risk to local partner. What does that tell us? How do we? So I think humanitarian as a whole, I think it's time to really look a little bit on the behavior and what we did over the last 10 years. And how could you be surprised when you move and you accept to be integrated into one mission in a context at war, then suddenly the other side look at you as an enemy. I mean, we need to be a little bit more savvy in that one. And my third message is about humanitarian space. I'm offering that to you, and maybe feel free to reject it. I think this is a misleading concept, because it gives this impression that there is a space, pure, protected, that you would move into a humanitarian space and move out. I never encountered that space. I don't know. And we should be careful about that, because it gives this impression that you should protect the space. But who protect the space? Army? Humanitarian corridors? I mean, what are we talking about? The reality is, I really prefer that we talk about, are we able to carry out humanitarian action, which is truly impartial, independent, neutral, we can discuss that, in situation of crisis, and especially in situation of conflict. I find that more interesting, because it gives us responsibility also to do it. This is all the trust questions, the engagement, are we able to connect with the needs of the people? Humanitarian space, I think, is misleading, because it gives the impression also that we are not responsible. We are.
Just very quick addition, because I do want to keep more time for questions, but I think it's definitely a question of different levels, and one of the things that I would underscore is our self-reflection as agencies on how we contribute or don't to, even by our silence on certain issues, on that instrumentalization process. And the shifting identities as agencies, sometimes we have as international agencies within UN, as of development, humanitarian, but also where we get our resources from also colors the way we are perceived in communities, and how we need to be more conscious of that. And it is an ongoing struggle. It's an ongoing struggle within most organizations on looking at that, except a few.
No more questions? No. Oh, sorry. And the lady over there afterward.
Please.
We can take both questions at the same time.
My name is Stephanie Ellis. I'm from the Medbox project, and I'm also representing a consortium of CBOs in Madagascar. I have a question mainly for Jasveen, but for all of you. Thank you, Jasveen, for leading into this question by saying, by commenting on the need to incorporate local perspectives into the humanitarian practice. I was just wondering, on the topic of healthcare and also in general, how can we better incorporate local perspectives? And you touched on spirituality and also, for example, male perspectives, especially in the field of family planning and these sorts of issues into humanitarian practice. And the second question was, can we comment on the underrepresentation of, you all spoke about humanitarians as us, but are we really the people that have ownership over these humanitarian issues? And I'm wondering, where are the populations, why is there such an underrepresentation of the populations that truly have ownership over these issues? Thank you.
Okay. It's a great one, and I can probably would love to spend a few hours talking about it, but I think it's in terms of incorporating local perspectives, it's something that needs to operate at many different levels, and there isn't, again, one solution for it. It's first of all the acknowledgement, and is partly something I personally, individually struggle with in agencies, is our Western paradigm of defining the way, especially within the humanitarian sector. And if you look at most deployable staff of most agencies, there are challenges of having that diversity within those teams itself. So it does, one part of that answer is it does affect the way one looks at the world, and which principles take priority over others. The advantage, I think, that at least for CARE we have as an organization is that we are a dual mandate organization, and in most of the countries where we do operate, we do also do longer term development programming, and that's where I feel the linkages between the two and recognizing the full circle of the crisis and then back to development and the protected context, protected crises that we have in most of these countries. In terms of where is the voice of the affected population or the population we claim we're working for, I think it's something that is central to the way we look at our own accountability as organizations. And I can say within CARE that there is a tremendous amount of work that is happening to make sure that that is not lost and that perspective isn't lost and is central to the way we operate and the way we look at our own identity as an agency.
Very quickly on that specific subject, and it's not a perfect response. I totally agree about the ability to bring the people at the field level. That seems critical. Just for us, what we're trying to have on that specific subject, healthcare in danger, is through community of interest, but also through association of practitioners. Doesn't mean you directly have population, but typically we have now a partnership, and I hope really that we can enlarge that with the World Medical Association, not the World Health, but the Medical Association. We want to bring also more doctors. I know it's official practitioner, but still, we need to understand also where they are. We need also to open that to communities, and we see that in country also, Women Association, whatever. I totally agree with that. We need to have them on board to influence also our take and to give a different perspective, because you can on that subject have different perspective. And it's important not only to capture them at the field level, but it's true also to project maybe about more nuance at the international level. And I hope we will be able to enlarge, in fact, the partners we have in this campaign. Yes.
I was wondering about the time after the danger, so about your exit strategies. What's going on at your project sites when your organizations are leaving, and do you conduct any long-term impact studies to evaluate your working? Yeah, to all of you.
Could you kindly repeat the first part of your question, please?
I was wondering about exit strategies. Exit, yeah, when you want to leave the country, as it should be part of sustainable work, that after you've done your work, you want to leave the country to their own entities.
Yeah.
Yep.
Exit strategies, particularly in healthcare, I think are very difficult. I'll give you one example of Sudan, of Darfur, where our big Darfur program has quite a strong health component, and we've been looking at how to hand those over to the Ministry of Health. Having looked at other attempts to hand health facilities over to the Ministry of Health, the budget just isn't there for them to survive. And so one of the conversations we've constantly had is, can we hand over if there isn't the internal budget for them to survive? I mean, we're giving them a very short time scale beyond it. So I think we need to be very realistic about exit strategies. As Caritas, very often, because it's the church that is responding, very often those health facilities have existed for a long time. So it's more a question of scaling back to the level of operation that they had before, and they have had long-term funding for those before. But I think we have done some impact studies, or after action studies sometime after, and I think evidence is very patchy as to how successful those have been.
It's a big question and it's a very difficult. We are struggling with it. I could almost say, and without joking, my question is, where are the entry strategy, of development actor? Because I always got message about exit strategy, but the reality is, to be honest with you, is we don't leave anymore. We don't leave context. I mean, this is over. We are in Sudan now since 40 years. We are in Israel, Palestine since now almost 50 years. We are in Yemen, Afghanistan. I mean, it's very rare that we leave. But then, where you have a good point, then it's not so much about the exit strategy, is how are we able, even in an emergency, when suddenly the situation is difficult, are we able then to take into our own practice some of the understanding about chronic disease, for example, which could be in a very difficult situation, start to be absolutely lethal. And typically for my own organization, if I look over the last 20 years ago, ICRC, and we can discuss if we were good or not, but we were very, very specialized into providing very specific medical care, mainly about surgical. We were working in a hospital and just treating really clearly patient, but then how do you do that when you are in a Mirwais hospital, at the core of Afghanistan, not at the same time start to look at the general situation of the hospital and of the patients. So, and that's a big issue for us. How are we able to do at the same time try to treat, specific needs, but also manage chronic problems, trying to understand the environment in which we operate and try to influence that. That's a big issue. And so far, in terms of development, yes, we need to make some bridge. But my point is, what I've seen so far is more of an issue about entry strategy than an exit strategy. At least, I would ask at least that question.
Just one point to that. I think the one thing that I prioritize within this context will be looking at beyond the operational response and the piece that you do around that. How do you engage with systems and structures from day one and not wait for an exit strategy? So, especially in contexts like Afghanistan, Somalia, Mali, and now Syria is where it is challenging, because you also have those multiple actors and it's not clear cut. How do we creatively engage with systems and structural issues is something we need to look at.
We can take one more question. Okay, sorry, 2 questions over there, and in the third row over here, and that's, yeah.
So my question is, you talk a lot about healthcare in danger, but I'm wondering about the legitimation of your work when the humanitarian aid is abused from conflict parties, so that the work will be used for the conflict parties to running along the war or something like that.
No, I'm not sure if I.
We're trying to see if we understood your question.
Were you asking if? I'm just clarifying the question. Were you asking how we deal with situations where you feel our spaces or services are being abused by one party or against?
There are a lot of situations, a lot of wars, where conflict parties use the humanitarian aid for getting stronger, for use the food, the medicines, and all these things for use for their own things, for their own, and so they can, and the humanitarian aid can reach the civil people and all.
Oh, very quickly, yes, there's a lot of places where over the last 10 years, this is something which we've seen with without being too long, with the fragmentation, especially of non-state armed group. Congo is a good example. Congo today, for the population, the situation for them is much more complex now than it was 10 years ago, not because of the level of violence, but because of the level of fragmentation of armed group. And of course, this armed group, they in a way have to finance themselves, and most of the times they have a very predatory behavior, not only towards humanitarian, but towards the population, absolutely. And that's a big issue. The only question here is how are we very, very aware of that? We need to be not naive about that. We need to be very aware. And again, that links me, the only response I can tell you is we need to have direct actions, to be on the spot again, not to just throw humanitarian aid to people. We need to be there. And I think the key element for us is repeating. Repetition is clearly, for me, key in humanitarian actions. Repeating the fact that you come back, you know, you've assessed the need, you come back to the places to see exactly what you said before, has been that the needs correspond and our response correspond to the need. Very critical. Repeat also that you come back, because it's the only way to see that people receive the humanitarian aid you give and to understand what's the dynamic, because there will always be pressure on the population. Repeat visit of prisoner, because even in a prison you don't repeat it, you put the people in danger. So I think it's the do not harm element, and the repetition is not a perfect one, but it helps certainly to progress in that dynamic. But it's still a big issue, I agree with you, and we have to be very careful.
All right. Last question.
Martina Metzler, I'm from Caritas, Austria. My question would be regarding something that's also mentioned in the leaflet, in the program, the security issue. And Mr. Daccord, you also mentioned the humanitarian space. I would like maybe the gentleman of the ICRC to comment on the current thinking about civil-military cooperation in this regarding the provision of healthcare.
Are you sure? It's a bit of a long debate. How can I do? Can I start with something different? Just because you raised me the questions on security, can I just share something with you also? Our practice, including in a very difficult situation in Afghanistan or in Sudan or now in Syria, our practice is to make sure, and I think it's important, that our security and the people in charge of our security and security of our staff is managed where it's happening. So in my sense, is my people, the people in Syria and Damascus, they are in charge of their security. I say that it's important because I've seen a lot of other humanitarians sometimes who manage security at headquarters, and headquarters decides the level of security. And that's already something very important to know. Decentralization of the management and have a clear autonomy of where your security is managed is absolutely critical for us if we want to be able to perform with all the problems we have, right? And we can then discuss that. On civilian military, you know, it was interesting. I was in Holland last month and had a debate with the chief of the army there and then the Minister of Foreign Affairs. And what I found interesting is a lot of countries right now in Europe are redesigning their civilian military strategy. And it seems to me that they've done that because they are obsessed by Afghanistan. Because in fact, in Europe, a lot of countries have, in fact, which is in a way new in the last 20 years, they went to war. In fact, they really, truly went to war in Afghanistan, and they had to learn, and they take the lessons out of it. I found that interesting. I think there is an engagement to be done and to look into that. I think there are different perspectives about that. But my point is, to frame it a bit differently, my point is, I think Afghanistan is the last war where we see large interventions of the international community as it is. My bet is, it's a bet, my bet is civil-military discussion will fade away because it won't be the war of tomorrow and after tomorrow. I don't think we will see anymore that many soldiers on the ground coming from Europe or from the US. I don't think so, for political, for also budget reason. And I think most likely, and this is a big issue I have, these days it's not civil-military relationship. The big issue we're dealing with is how are we able to engage in a context where, for example, you have drone being used. How are we able to engage now with possibly what is happening, which we can call it a cyber war? How do we do that? how are we able to make sure that international law, that in fact states are ready to rediscuss the questions of proportionality, for example, of distinction between civilians and military objective. I don't know how it's happening when you launch a virus. And I'm not saying I don't want to discuss civilian military, but what I'm just saying to you is, let's be careful. It's an important subject, but I don't think it should be our main target in a way, or a main discussion. We are obsessed, rightly so, by Afghanistan, and rightly so, and I hope, by the way, that the commitment will stay, but let's be very careful. It won't be the new war. The new war will be very different, and I don't think we will see that many of, let's say, Western soldiers, if I talk about that, and Western country intervening as it is.
Thanks very much, Yves. I think it's very interesting, your comments about the changing nature of war. And if that means that there aren't soldiers in theatre, then that will take away one problem, but it will obviously create a whole host of other problems. So the other thing I'd add to it, though, is I think the debate about civil military was originally one about ground rules, about how do NGOs and military work when they're in the same geographic area. How do you cooperate or not cooperate? To what level can you cooperate? I think the nature of the debate changed about 6 years ago, when it became much more at a level of policy and this whole instrumentalization, because then we were no longer talking about do we engage, don't we engage, how do we engage? Actually, it was being written at a completely different level, which is why I think coming back to this engagement around the humanitarian principles with policymakers is so important. But that won't get us over the questions of how do we deal in theatres where drones are at play or where there's a changing nature of war.
No, the only debate interesting now, sorry, just to come back, I think our take is the following one is, we do understand that you could have military intervening in a context. We see that Mali is a good example right now. What we're requesting is that there is a clarity about the objective. Right? Very clear. I mean, that's very clear. And we would really, and in our debate with civil military discussion is, let's make sure, including, by the way, for the military. Frankly, I think for military, they are in a much better position if the politician and to whom they report have fixed clear military objective. They know exactly what they're doing, instead of putting humanitarian objective for, in fact, a military operation. And it's the blurring of the objective which is the most problematic. That's really the thing. And there is not only an issue of perception, we know that, and relationship, but there is also a major issue of accountability. And I found that very problematic still today.
Right, thank you. We are running out of time anyway. I was waiting for a positive closing remark like in the session before. There is none, so I take this into account. Thank you very much for attending this panel. Thank you very much for your questions and attention. The panelists will be around during lunch break, which is commencing now, and we'll see each other again at 1:30 for the sessions Humanitarian Aid and the Media, and Humanitarian Aid all inclusive. Thank you very much.